my name is Tamara Reyes, and this is my concept map on my patient who had enterocolitis. So, the basic pathophysiology of enterocolitis is just that it's inflammation in the inner lining of both the small intestine and the large intestine, and it can be caused by many reasons. It can be caused by medications that you use, it can be caused by a disease that you have, an infection. There's many reasons that someone might have enterocolitis. So for my patient information, my patient was a 63-year-old male. I had him on the 26th of February. He was a full coat and allergic to lisinopril. For considerations of care, he was a divorced father of one. However, he had no contact with his daughter. And he stated that he lives with his sister and brother-in-law at their house. And he seemed to have a pretty good support system from what I can tell. When asked about cultural religious considerations, he said there was nothing specific that we needed to know when caring for him. So this is kind of how he presented at the ED. He presented with severe abdominal pain and distension. He noted that he was taking more narcotics than usual that were prescribed to him for his chronic pain, but he was taking way more than usual, and he was constipated for a week before coming to the ED. So not only can enterocolitis affect your intestines and your GI system, but it actually can affect all of your organs. And so it depends what causes it and what that leads to. For the brain, in many cases, severe enterocolitis can cause dehydration and electrolyte imbalances, and those can alter brain function. In the heart, an electrolyte imbalance, again, because of, inadequate intake and output. Electrolyte imbalances can cause arrhythmias, which can cause more issues in the body. The liver is a filtering system for our blood, but if we don't have enough fluid and you become hypotensive, then your liver is not going to work properly. As for the lungs, in the case that enterocolitis was caused by infection, it can trigger our immune system and actually cause ARDS, acute respiratory distress syndrome. And in that case, the patient would have a low respiratory rate, shortness of breath, low O2 sat. Obviously, it predominantly affects the gastrointestinal system. So a lot of patients with enterocolitis decrease gut motility, so they're not able to poop, they're not able to have a natural bowel movement, and they can have constipation that is severe and causes distension and inflammation and firmness in the abdomen. And lastly, if the patient is severely dehydrated, the kidneys will suffer and they won't be able to function properly. And they can actually have acute kidney injury because the blood flow is not adequate to the kidneys. So this patient had a couple of cues that I wanted to point out. Most of his vitals were okay. His O2 was kind of borderline, but like I will mention a little later, he does have history of COPD, so it was kind of expected. His pain was very high, and his BP was slightly high as well. So signs and symptoms that he presented with was firm distended abdomen, diminished bowel tones, and an 8 out of 10 abdominal pain. They did do a CT scan pretty immediately after admitting him. They did not find an obstruction, but they did find some fluid in his small bowel and colon. His small bowel in the left abdomen was prominent with wall thickening, and his gallbladder was slightly distended, but no obstruction per the CT scan. For his labs, he did have a high white blood cell, which could indicate maybe an infection, but they didn't find anything with that. His TSH was low, his A&G ratio was low, and his albumin was low, which I'll talk about later. So his drains, his NG tube was inserted pretty immediately to try to get off that distension and firmness in his abdomen. And then some relevant past medical history. He was taking narcotics for chronic pain more than usual, and a big side effect of narcotics is constipation. So that was pretty relevant. He has hypothyroidism. He has history of COPD, tobacco and alcohol abuse, hypertension, which shows with his BP, and then a leg stent on Plavix. My initial analysis of all of these cues was that the patient's development of enterocolitis was likely due to his overuse of narcotics. Overusing narcotics can cause severe constipation, like I said, and backup in the intestines. Um, if the patient may have come in any later, he might actually would have had an obstruction. Um, Luckily, he came in just on time and we were able to help him. And our goals for his care should be to reduce his symptoms of the enterocolitis and help him get his GI motility back up to speed. My number one hypothesis and concern is his backup in his intestines. So it was impaired gastric emptying related to enterocolitis. Um, my number one goal was to try to have him have a bowel movement, try to do all the things to try to help him do that. So my goal for this priority was by the end of my 8-hour shift, my patient will show improvement of impaired gastric emptying by having significant output from his NG, reporting that he's passing gas, reporting pain decrease, a less tender abdomen. He was having mild tenderness, but even no tenderness would be great. And then having a less distended abdomen. Those would all be signs that his emptying was improving. So, the main ways and interventions that I would do for this priority to be met is by monitoring his intake and output, encouraging activity to help increase his motility, encouraging him to move around and try to make his gut motility increase, and then ensuring that he adheres to bowel rest. This patient was placed on bowel rest as soon as he had that NG tube in. And so, just doing a lot of patient teaching on why he's on bowel rest and making sure he adheres to that. For my outcome, I put that it was ongoing. The reason I did was because my patient didn't have a bowel movement during my shift. However, he was having a good amount of output and he was passing gas and he was urinating well. He just had not had a natural bowel movement. So I just say it's ongoing for now. For my second hypothesis, I put risk for deficit fluid volume related to excessive fluid loss. Um, so he did have an NG tube and it was having lots and lots of output. And so he was losing a lot of fluid. So my biggest concern was just that he had a great fluid loss. So I wanted to make sure to keep an eye on that throughout my shift. So my goal for him related to his dehydration is by the end of my 8-hour shift, my patient will not become dehydrated by administering IV hydration, tracking his eyes and nose, assessing him for like minimal output, and assessing his urine for signs of dehydration, like if his urine is super concentrated, and then assessing his level of consciousness, because obviously dehydration can cause you to be confused. So I wanted to constantly be assessing him to make sure he didn't have any of those signs. So the main ways that I did those things were monitoring his eyes and nose closely, administering IV fluids to keep him hydrated since he was on bowel rest, and then monitoring his output characteristics. If his and G tube output was getting darker, getting lighter, if his urine was concentrated or not. I was paying attention to all of that. So I would say that I met this goal. My patient did not show any signs of dehydration throughout my entire shift. Um, he was on bowel rest, so he was at high risk for dehydration because he couldn't get any oral hydration. However, by using the IV and monitoring him closely, we made sure he didn't get dehydrated. So, for my last hypothesis, I did knowledge deficit related to medication management because I believe that his constipation came from all the narcotic use. That only leads me to believe that he had a knowledge deficit and didn't really understand the side effects and the dangers of overusing narcotics. So, for that reason, I made this my third hypothesis. So, my goal for this priority was just that by the end of my 8-hour shift, my patient will report understanding of the medication teaching that I was giving him by being able to explain the side effects back to me, explaining how his overuse of narcotics affected his bowels, and then explaining how the dosage and use of his medications affects him, and being able to explain the reason he is prescribed his medications and why he's taking them. So, to help him reach these goals, I made sure that I did adequate patient teaching in clear, simple layman's terms. I encouraged his questions and feedback and input in case he was confused about anything I said, and then I used the teach back method as my method to make sure he was understanding. So by the end of my 8-hour shift, my patient did report understanding of the medication teaching. He made sure to use the teach back method to let me know why he was taking certain medications, and I even took time to explain the ones he was taking at home, because he knew what he was taking at home, but he didn't really understand why he was taking it or even the dosage of it. We had a good conversation, and he was able to tell me like what he didn't understand. I did make sure to try to explain the use of narcotics was likely what caused him to end up in the hospital, and so I just explained to him that he needs to adhere to the dosage and the way that they tell him to take his medications, because ultimately it's obviously for a reason. And he expressed understanding and let me know that he just wasn't aware of those side effects and he didn't think that anything was going to happen, and so he learned his lesson. I wanted to kind of circle back to his relevant medical history because I saw that he did abuse tobacco and alcohol, and I'm sure he was told, why that's bad and how that can affect him. And so I kind of took that as a cue to how he would respond to patient teaching. I'm sure he has been told many times that alcohol is bad for him and smoking is bad for him. Um, but he obviously still uses those things. So when I did my patient teaching, I tried to use his current situation as a way to teach him, like, hey, you're here because of this, and I understand that you have chronic pain, and maybe you thought that it was going to help you, but the dosage is there for a reason, and kind of try to tie it back into his current situation rather than blaming him, to try to help him understand. I did want to touch base on a couple of these cues that I didn't really go in depth into earlier. So his white blood cells being high. Your white blood cells go high when the body is responding to some sort of stress or condition where the body's trying to fight it off. So it could indicate that there's an infection, but it also could just be the inflammation and the body's just trying to fight off whatever it thinks the enterocolitis is. His A&G ratio is also low, which can indicate it can be caused by the inflammation. And because enterocolitis is inflammation of the intestine, it makes sense why his A&G ratio is low. I thought it would also be interesting to point out his albumin. So his albumin is low, and albumin actually helps keep fluid in our blood vessels. And since there's not enough, it makes sense that this would contribute to the fluid building up in his small bowel and his colon, because he did have fluid accumulation there. And so that could tie in directly to that fluid. Overall, this patient did require a lot of patient teaching. Um, he's pretty independent at home, and he does live with his sister, but he stated that he's pretty much alone all the time, and it makes sense that he didn't understand a lot of the things. Possibly when they prescribed him those narcotics, he just didn't adhere to it and didn't really feel like he could ask questions. So I just made sure to make the basis of all of my care patient teaching, because it seemed like this could be something that could have been avoided had he understood his medications that he was taking and why, etc. Um, so I just made sure to really try to have a relationship with him, and a trusting relationship where he felt like he could ask me questions, because if this was because of a knowledge deficit, and it could have been much worse had he come in much later, I wanted to make sure it wouldn't be a problem that would happen again. He does have chronic pain, which is gonna be pain that he has forever. So I just tried to make sure that he understood that I just didn't want this to happen to him again. He obviously was in a lot of pain and he didn't want this to happen again. So I tried to tie it back to his situation in the moment and how he could have avoided it and how he can avoid it in the future moving on. He's still going to get those narcotics. He's still going to take all those medications that he takes. But I just wanted to make sure that he was educated on them and really understood why he was taking them and how exactly to take them, because it can be very dangerous. Overall, my patient did very well. He met 2 out of 3 goals that I had for him for the day, and even the one that he didn't completely meet, he did do very well on. I explained to him my goals for his care for the day. He agreed, and I think he did a great job trying to adhere to them. There were some moments of confusion where he didn't really understand certain things like the bowel rest, but ultimately, I believe that we had a great day together.